This is your Week 6 lecture on allergies and allergic reactions. We only have one topic this week, but it is a very important one in terms of medical emergencies. On the back side of the medical history form is where you'll see the allergies section. You can see that there are lists of items that are commonly used or prescribed in the dental office, such as local anesthetics, aspirin, penicillin, or other antibiotics, sedatives, sulfa drugs, codeine, other narcotics that may be prescribed, metals. We use a lot of metal instruments and sometimes metal prosthesis, latex used in gloves commonly, and other items as well that are not necessarily used in the dental office. So it is important for us to know, especially any allergies to products that are used, but we are also concerned about products that might not be used or substances that might not be used. And the reason being is that a patient with any allergy are at an increased risk for having an allergy to other products. So if you have an allergy, you're predisposed to having other allergies. This is what we call atopy. And these patients are considered hypersensitive to a lot of different allergens. So when we see an allergy of one substance, we may be suspecting that they could have an allergy to something we might use. So any known allergies that a patient marks as on their medical history is going to require a medical alert sticker to be placed in the upper right corner of the medical history form, as well as the upper right corner of the patient's chart. An allergy is a chronic condition that involves an abnormal response or a hypersensitive response to an otherwise harmless substance known as an allergen. So many people have no issues with certain allergens. They're harmless to them, and some people have a hypersensitive response to them, and that is their allergic reaction to a certain allergen. So a overview of allergic reactions, they can be a very wide range of different manifestations. So they can just be a certain small rash or redness, all the way to bronchospasm and having cardiovascular involvement. In general terms, the faster the response, the more severe the allergy will be, and the more aggressive treatment that you'll need to do to manage it. So if something happens within 30 seconds of being exposed to the allergen, rather than 20 minutes, the 30-second one is going to be more severe and will require you to act quickly and more aggressively. It's also important to note that allergic responses are not dose dependent. This is different from side effects. So it doesn't matter if you have a little bit of the allergen or a lot of the allergen. It doesn't matter how much to elicit the same response. Allergies are not considered to be adverse reactions, side effects, or toxic overdose. So it's not a side effect of an allergen. So something like nausea, that might be something that someone gets when they take a certain antibiotic. That's a side effect of the antibiotic, not an allergy to the antibiotic. So you have to be able to distinguish between someone having a true allergy and a side effect. And that's going to be done through questioning. The pathophysiology of an allergic reaction is pretty complex, and for this class we are going to try to keep it as simple as possible. If this was a microbiology class, we would get into it in more detail, but for this class we're going to be pretty simple about the allergic reaction response. So in essence, it's an immune system response, and it involves a substance, an outside substance, which is called an allergen, that provokes the body's immune system to respond to it. It's a hypersensitivity reaction to an otherwise normal or harmless substance. How allergies work and develop, there is an initial exposure of an allergen, and this initial exposure is called sensitization. During this initial exposure, there is usually no observable reaction. So the person is exposed at the first time. They don't have a reaction to it. And this is when, in your body, your immune system is recognizing that substance as an allergen. It metabolizes it and creates an antigen. That antigen provokes the production of antibodies. And then memory cells develop, and they are responsible for the secondary immune response. So you have these memory cells that remember that allergen and have that certain antigen, and they remember to call in the production of antibodies. So that is how when you're exposed the second time, or the next time when you're re-exposed to that allergen, those antibodies detect that offending allergen. They bind to it and try to come fight it. They try to neutralize the allergen. That process is called the antigen-antibody reaction. And then on that re-exposure, that secondary or so on and so forth after that, then you're going to have those observable signs of allergies. And that's what we know as rashes and swelling, redness, and then even more severe, something like your throat swelling or the lips swelling, and then even more severe bronchospasm when your lungs are constricting and you're having trouble getting oxygen and breathing. This slide is a review of some of the key players in allergic reactions that I mentioned on the previous slide. So there's the 3 A's, the allergen, the antigen, and the antibody. Our allergen is the offender. It's the substance that causes the hypersensitive reaction. It is what the body is reacting to. So that could be something such as dust. It could be a bee sting. It could be a food. Then we have the antigen. That is a molecule that evokes the production of one or more antibodies. So this is the molecule in the body that tells the antibodies to come to where the offender is. It tells it to come and fight off that offender. And this is what I call, it's kind of like the tattletale, if you want to think of it that way. Then we have the antibodies that come in. These are also known as immunoglobulins. They are proteins that are produced and stimulated by a specific antigen to neutralize a specific allergen. So they're very allergen and antigen specific. There's going to be certain antibodies for each of those. If someone has multiple allergies, different antibodies are going to respond to the different kinds of allergies. So we have, so the immune system has B lymphocytes that can come to fight off the allergen. There's also different classes of immunoglobulins, and they're abbreviated as IG. So we have IgA, IgD, IgE, and IgM. And each of them differ in function, and depending on which immunoglobulin or if it's lymphocytes that are coming to neutralize the allergen, you're going to get a different kind of allergic response. So a different kind of, rash or redness or anaphylaxis. And that's something we'll talk about. There's different types of hypersensitive reactions, and we'll talk about those in a few slides from now. Here's a review slide that shows the pathophysiology of allergic reactions. Again, it's much more complex than this, but we're keeping it as simple as possible for the uses in this class. So we have the allergen, the offending substance that starts that immune response. The antigen in the body that calls upon the antibodies. It evokes them to come to where the site of the allergen is. The antibodies are proteins or immunoglobulins that try to neutralize or fight off the allergen. And when those antibodies are doing so, they cause a reaction. So they release certain substances that result in certain signs. So we'll talk about histamine that's released and how that causes different kinds of reactions. So we have rashes, redness, swelling, all the way to bronchoconstriction, and even cardiovascular involvement. Our bodies come in contact with different allergens several different ways. We can touch them, they can have contact with our skin or mucous membranes. We can have an injection, so something like a bee sting or something that like medication that's injected. You can ingest it, food allergies, or just oral medications, and also inhalation, pollen, dust, dander. So remember that allergies are abnormal responses to an otherwise harmless substance, and they are not dose dependent. It doesn't matter if someone has 1 or 10 peanuts, that 1 peanut's going to cause the same allergic reaction as 10 peanuts would. There are 4 types of hypersensitivity reactions. So based on the immunoglobulins involved and the chemicals or substances that are released by the antibodies are the different types of reactions that they can have. So this slide 1 through 4 gives you some key words to help you remember which what words you can correlate with each type. So type 1s are immediate. They're also responsible for anaphylactic shock. Type 2 involves cytotoxic, so it's lysis of cells. Type 3 is immune complex, and type 4 is delayed reactions. So you can see that type 1 and type 4 are very different from each other, because type 1 is immediate versus type 4 is delayed. Type 1 reactions are the most common type of hypersensitivity. They are immediate reactions, so these are going to be occurring within 30 seconds to a couple minutes. They are caused by immunoglobulin E or IgE antibodies. I want you to know the antibody associated with type 1 reactions. When the antibody binds to the antigen, so when it comes to the site of the offender, 3 substances are released: histamine, leukotrienes, and prostaglandins. Those 3 substances are what is going to be causing the reaction that we see. They cause vasodilation and edema and some other signs. So a usual skin reaction is urticaria, which is the medical term for hives. That is the raised red bumps on the skin that are usually itchy. Less commonly is bronchial constriction and hypotension that would lead to cardiovascular collapse. So type 1 reactions, 3 substances are released: histamine, leukotrienes, and prostaglandins. Those substances are causing vasodilation and edema. The usual skin reaction is urticaria, and less common is when we have the more severe reactions like bronchial constriction and hypotension. The main chemical mediator in a type 1 reaction, the main substance that we're concerned about that's being released, is histamine. It causes vasodilation and edema, and in severe reaction, that vasodilation is going to decrease the blood return, resulting in a drop in blood pressure. Remember, vasodilation, your blood vessels are dilating, and that's why we're getting a drop in the blood pressure. Histamine also in severe reactions can cause bronchial constriction, and histamine is the major mediator in anaphylactic shock. So anaphylactic shock is a type 1 reaction, and it's a severe life-threatening reaction that involves those 2 aforementioned things: vasodilation resulting in low blood pressure and bronchial constriction. So it's very acute, it happens very, very quickly, and it's life-threatening. Again, anaphylactic shock is a type 1 reaction. There is hypotension, bronchospasm, laryngeal edema, and cardiac arrhythmias involved in anaphylactic shock. It leads to respiratory distress and cardiovascular collapse. So it's extremely severe. It happens very quickly, and we need to react very quickly if we suspect anaphylactic shock. There are drugs and products that are used in dentistry that have caused anaphylaxis. Penicillin, it's one of the most allergenic drugs. Ester type anesthetics, we'll talk about that when we talk about local anesthesia allergies. Tetracaine is another local anesthetic. Aspirin and latex is a very common product to have an allergy and also to cause anaphylaxis. Type 2 reactions are considered cytotoxic. This is because they involve lysis of host cells, and lysis means the breaking down or dissolving of the cells. They are caused by IgG and IgM antibodies and are considered complement-dependent reactions. Complement is an enzymatic serum protein that causes the lysis of the cell. So it's an enzyme that breaks down the cell wall and causes lysis. So you can remember that type 1 reactions are cytotoxic and they're complement dependent. That complement is the enzyme that's causing that lysis of the cell. Type 3 reactions are also known as Arthus reactions or immune complex reactions. They're caused by IgG antibodies, and they're similar to type 2 because they both involve complement, but in type 3 reactions, complement is deposited in vascular endothelium. Again, complement is that enzymatic serum protein that causes lysis of the cell. Type 3 reactions are manifested as serum sickness, and they have symptoms of arthralgia, arthritis, lymphadenopathy, fever, and urticaria skin lesions. Again, the hive reaction. Type 3 reactions have occurred after injection of the hepatitis vaccine and penicillin administration. The key word with type 4 reactions is going to be delayed. Type 4 reactions have a delayed reaction. They usually occur several days after contact with that allergen. They're different from all 3 other reactions because they are mediated by T lymphocytes and macrophages. So we're not talking about immunoglobulins for type 4s, we're talking about lymphocytes and macrophages, which are both white blood cells and part of our immune response. Some examples of type 4 reactions are allergic dermatitis from metals. So in that picture on the right-hand side, you can see an ear with an earring. So this person might have a sensitivity to metal. And in this circumstance, if it's a type 4 reaction, we can presume that she's worn the earring for a day, a couple days, and then after that is when the redness and swelling started to occur. So there's maybe a very mild reaction to the allergen. Another really good example is poison ivy. You can think about if you've ever gotten poison ivy, you come in contact with it at some point, maybe walking through the forest or the woods, and don't really remember when, but a few days later you notice that you have an itchy rash on your skin. So it doesn't happen immediately, it's very delayed, a couple days afterwards. And because it's so delayed, we don't have to treat it so aggressively. This is not like anaphylaxis that's going to require a lot of treatment. Antihistamines, such as Benadryl, is what someone would take if they got a type 4 reaction, and corticosteroids, so some kind of topical cream is usually put in the area. When someone marks yes for an allergy, we need to be asking follow-up questions. So if some examples of follow-up questions that we would ask, if someone checks yes to a local anesthetic allergy, the medical history form just says local anesthetic. There are several different kinds, so we need to be asking what type was used and what type of reaction did they have. Did they just swell up? Did they have anaphylaxis? Did they faint? So sometimes people think that they have an allergy if they experienced a side effect. So something like syncope from fear or anxiety during an injection is not an allergic reaction, it's a physiological response. So just because someone fainted from an injection doesn't mean that they are allergic to that type of local anesthetic. So you need to be able to dig deep into the reaction to decide if it's truly an allergy or if it's just a side effect or bodily response. And then what was the duration from the exposure to developing signs? So we want to know, was it immediate? Did it take a while? Or was it extremely immediate and they had an anaphylactic reaction? Same goes for a medication. What kind of reaction did they have? Again, some people might list nausea as the reaction. Nausea is going to be a side effect. It's not a allergy to the drug. Just having nausea to an antibiotic doesn't mean you're allergic to it. And another question you would want to ask is what kind of medications, so if they said they were allergic to a pain medication, what have they taken successfully? What antibiotic have they taken successfully? So in the event that you would need to prescribe something, you know what would work for that patient. And then someone who's checking yes to something that we're not necessarily using in the dental office, such as food or dust, hay, just following up and making sure, have you ever experienced any kind of reaction to the dental office? Remember that some people have a genetic predisposition to have allergies. That's the atopy definition. So if a patient has atopy and they are allergic to certain fruits or to dust, we can have allergies to products that are used in the dental office that may have never been used on them before. So we want to make sure that we realize that someone with an allergy is more prone to being allergic to something else and keep that on our radar when we're using different products. More information on a local anesthetic allergy. So again, we need to be making sure that the patient has a true allergy or could have been potentially an overdose. So again, syncope is not an allergy. It's a physiologic response to fear and anxiety. And increased heart rate is a side effect of local anesthetic. Because epinephrine is in a lot of local anesthetics, it can cause an increased heart rate. That is a factor. Epinephrine is a vasoconstrictor, and it also increases the heart rate. So if someone checks that they have a local anesthesia allergy and said it made their heart race, that's not necessarily an allergy, but it could be due to getting too much, so an overdose of anesthetic, or maybe a reaction to the amount of anesthetic given, not necessarily an allergy to that anesthetic. We also need to be finding out specific information. So we need to know the exact name of the drug. So a lot of people throw around the term Novocaine, and Novocaine is just a generic term. It's actually a very old anesthetic. We don't ever really use Novocaine in the office. There are specific specific names of anesthetics that we use. We use lidocaine, we use mepivacaine, we use Marcaine. So if the patient says Novocaine, that's probably not the anesthetic that was used. We want to know the amount that they administered. We want to know if there was any vasoconstrictor in it, what kind of preservatives were in it, because we need to know if maybe it was a reaction to a preservative in the anesthetic. If patient was taking any other medications at the time of the local anesthesia episode, and what exactly occurred pre and post, and what kind of treatment did they render for that patient. So this is a lot of information, and patients may know this, but they also may not. So if they're unable to provide this information to you, a quick phone call to the dentist that treated them during this emergency. Everything should be recorded in that patient's chart if they're properly taking their notes. And if it's unclear why they had the allergic reaction, then we may need to have medical consultation to determine the exact cause of their allergic reaction. A local anesthesia allergy is going to warrant a medical alert sticker. So we'll be placing that in the chart, or on the chart, and on the medical history form. If there is questionable history regarding the allergies, so if the patient isn't able to successfully tell you, and the dentist, the previous dentist that they had the issue with isn't able to tell you the issue that they had, or the reaction that they had, or certainty of what the reaction was caused from, we may need to postpone treatment until we can figure out the cause. So a patient may need to go to an allergist, a controlled environment in which an allergist can administer certain substances to find out if it was a reaction to one of the preservatives in the local anesthetic, or potentially the local anesthetic itself. And then as a last resort, if we cannot find the cause of the reaction, a last resort would be doing something such as general anesthesia, where a patient was actually sedated to get the work done that they needed in a comfortable manner. Penicillin is the most allergenic drug. So if you are in practice and you're experienced reading a lot of health histories, that's going to be your most common drug that you see people checking that they're allergic to. Thankfully, most people just have mild skin reactions to penicillin. Many people don't even know what happened, because they had it as a child and they've never had it since. And their parents told them that they were allergic to it. But there's also anaphylactic reactions that have been recorded. We commonly prescribe penicillin and its partner amoxicillin in dentistry to stop oral infections, help oral infections, or prevent them. Remember that nausea is a side effect. It's not an allergic reaction. So if someone tells you that they have a nausea, you can tell them that it's a side effect, not necessarily that they're allergic to it. But other antibiotics can be prescribed. They're not our first line of choice, but they will do in the case that someone's allergic to penicillin. Again, a medical alert sticker is going to be needed to be placed on the chart for an antibiotic allergy. Latex allergies are pretty common. And they have significant management implications. So there's a lot of things in the dental office that contain latex. Our rubber tubing, our gloves, there's latex gloves, and I know all of you were instructed not to get latex gloves, and a lot of offices these days don't have any latex gloves. But a lot of older doctors started using latex gloves, and they really like the feel of latex gloves. So a lot of times you'll see older physicians or older doctors still using latex gloves in the office. Sometimes the elastic on masks, especially surgical masks, have latex in them. The polishing cup, so when your dental hygienist is polishing your teeth, sometimes that polishing cup can contain latex. And also rubber dams that are placed during endodontic treatment, or sometimes for fillings. So if someone has a latex allergy, it's required that the dental office has non-latex products when they're treating that patient. You can't just say, oh, we only have latex, so let's hope that nothing happens. latex allergies can cause anaphylaxis. So we want to make sure that we always have the option to not use latex products. And you'll see, as far as the polishing cups, when you go to purchase them and on the box, they'll say non-latex on them. So things that used to have latex, they're coming around and they're making it very clear when they do have contain latex and when they do not. But you do need to make sure you're aware and you're looking for that when you're in a dental office. And again, this allergy is going to require a medical alert sticker. Okay, so we're going to start discussing the signs of allergic reactions. So the first one is skin reactions. This is pretty common. These are usually where allergic reactions start on the skin. So this is known as contact dermatitis, and it can manifest as erythema, which is redness, edema, which is swelling, and also vesicle formation. Vesicle formation is the picture on the left, and they're little pus-filled nodules on the skin. On the right is a picture of urticaria or hives, and you can see the redness and color, the little bit of swelling of the skin, it's raised, the well-defined borders where it's red versus where it's white, and also this person probably is itching. Next, when the process continues, we get to angioedema. This is swelling of the lips, the tongue, the eyes, and then in some cases, if it progresses even further, it can progress to the larynx. This is known as laryngeal edema. At this point, we have no cyanosis, so we're not seeing, cyanosis is a bluish color, and that's due to lack of oxygen in the blood. So we have no respiratory issues. We don't have a lack of oxygen at this point, so we're not going to see bluishness in the lips, sometimes in the extremities or the fingertips. At this point, we just have localized swelling, and usually that's around the lips, as you can see in the picture there, maybe a little bit in the tongue, and then as it progresses, the larynx. If angioedema extends to the larynx, the vocal apparatus is going to swell, and you're going to start getting obstruction of the airway. So you can see the picture in the middle there is of the larynx, and we see the epiglottis, we see the vocal cords. If we have a swelling of this area here, we're going to start having obstruction of the airway. The person's going to start having difficulty breathing. So at this point, if you're seeing the angioedema starting in the lips, you want to make sure that you're questioning your patient and asking them, do you feel like you're having any swelling in your throat? Are you having any difficulty breathing? Are you having difficulty swallowing? If this is happening, a person can start to experience cyanosis, that bluish color of the lips. That's the picture on the right-hand side. If this continues to progress, we can be getting towards a life-threatening situation if we don't act. The next sign would be respiratory reactions. These, and if you're having a slowly evolving allergic reaction, respiratory symptoms or reactions are going to occur after we have skin reactions, after exocrine reactions, and if there's any gastrointestinal responses. But they're going to precede any cardiovascular signs. So they're going to fall between those four. Bronchospasm is going to be the classic respiratory manifestation. So if there's respiratory issues, we're thinking about bronchial constriction and then bronchospasm. Here's another slide on anaphylaxis and the process of anaphylaxis. Again, it's a life-threatening reaction and can cause death in just a few minutes. So it's extremely fast moving, and it is not dose-dependent. So again, you don't need to have a lot of the allergen to cause the reaction. Most fatalities, if anaphylaxis is occurring, occur within the first 30 minutes. It's a type 1 reaction, so remember, type 1 is immediate. And the usual progression of anaphylaxis starts with the skin, so any kind of contact dermatitis, moves to the eyes, nose, throat, swelling of the lips, angioedema, moves on to the respiratory system, where you see constriction of the bronchioles, bronchospasm. This might be leading to cyanosis, the bluing of the lips and the fingertips and toes, the extremities, and then could turn to the cardiovascular system and get that involved in the most later stages of the reaction. Another type of reaction that I wanted to add into this lecture is called anaphylactoid reaction. Not to be confused with anaphylaxis. The reaction is very similar to anaphylaxis, but what makes it special is that these reactions do not have to have that initial sensitization like the others do. So we talked about how in most allergic reactions, the initial time someone's exposed to the allergen, there's no observable reaction. They have this initial sensitization, and then the reaction comes when they have that re-exposure on the second exposure. In an anaphylactoid, you do not need to have that. So it can be the first time that someone's exposed to it, and they have this anaphylaxis reaction. So drugs are the most common injected drugs or oral drugs that people ingest are the most common trigger for anaphylactoid reactions. Our prevention strategies for preventing allergic reactions, we want to do a careful review of the medical history. We cannot forget to review this because of the potential for us to use products that patients are allergic to. You never want to get caught with your tail between your legs using a product that a person's allergic to and that they reported it to you and you did not take note of it. So definitely are paying attention, a careful review of that. And again, that's why we put those medical alert stickers, so that's something that we are extremely aware of. Patients that have any allergy are more likely to have other allergies. So I think it's interesting to note that patients that are allergic to tropical fruits, such as bananas, kiwis, mangoes, and other things, are often allergic to latex. So they found a correlation between those two things, even though they're not related at all. And we want to make sure we're asking those appropriate follow-up questions. We want to know if it's truly an allergy. We want to know what was the product they used exactly and what their reaction was to it. Even with the best prevention and best review of medical histories, there's always the possibility of a patient having an allergic reaction in our chair. We may use a product on them that they've never had before, and that might trigger an allergic reaction. So we need to know how to manage it. At any signs of allergic reactions, we're going to make sure we terminate dental treatment. We need to stop what we're doing, remove anything that may have caused the allergy, and observe the patient. We're going to be seating them comfortably. So if it's just a skin reaction, or if they're starting to have respiratory distress, swelling in the lips, the tongue, potentially the larynx, and moving down into the bronchial constriction, that's when we're going to start to get a little bit worried, but we're going to be seating them upright. If we notice that they're having some cardiovascular involvement, so if they're starting to be unresponsive, or their blood pressure is extremely low, or their pulse is extremely low, we're going to be seating them in the supine position. We need to assess our ABCs, airway, breathing, and circulation. So, is their airway clear? Are they having any constriction of the larynx that you can see? Is their breathing normal? Is it labored? Is it wheezing? Are they having difficulty breathing, and you can tell by their body language? In circulation, what's their pulse? What's their blood pressure? When we assess all of this information, we're going to start to initiate our definitive care. To decide what kind of definitive care to provide, we need to determine what kind of reaction they're having. What are their signs of their reaction? And how is it progressing? So if someone's just having a skin reaction, redness, swelling, if their lips are swelling or their tongue's swelling and it's staying localized, and there's no respiratory distress, no cardiovascular involvement that you can tell, for this person, and especially if it's slower moving, we're going to not be as aggressive with our treatment. We can give an oral antihistamine such as Benadryl, or we can give a histamine blocker intramuscularly, and that will be found, both of those items will be found in our emergency kit. This patient, you're going to watch them recover. You're going to monitor their situation. You're going to continue to monitor their ABCs. You're going to continue to monitor any kind of swelling and try to see the effects of the antihistamine working. If there is respiratory or cardiovascular involvement, we need to act fast, especially if it's occurring fast. We may be having an anaphylactic reaction. For someone having respiratory or cardiovascular involvement, we need to administer epinephrine. Epinephrine is going to be our drug of choice for treating anaphylaxis. Usually, we would be administering this via an EpiPen intramuscularly. I'm going to bring an EpiPen to class, and we are going to look into practicing how to use an EpiPen. It's either given in the thigh or the deltoid, which is up in the upper arm, and that's in the muscle. Or they do have vials of epinephrine that you can administer intravenously. If we're seeing this going on, we're getting that EpiPen, we're using it, and the next thing we're going to be doing is, this is all hands on deck, everyone in the office should be around and helping with this emergency. We're going to be getting someone to administer oxygen. Someone's going to be calling 911. And if we see that the cardiovascular involvement is progressing into loss of consciousness and loss of breathing, then we're going to need to administer CPR. Finally, the last thing we're going to do to manage an allergic reaction is document. Document everything. When it happened, how long after exposure did it happen, how quickly did it progress, what kind of reaction, what was involved. Was it just a skin reaction? Did it progress elsewhere? What did you do to manage it? And what was the resolution? Did the patient take a antihistamine and recovered and went home? Or did you have to administer an EpiPen and the patient had to be escorted by the EMS to the emergency room? So below there, I actually screenshotted my notes that I made a few weeks ago. You can see it was on September 7th of this year. I had a patient who had an allergic reaction. Thankfully, it was a mild allergic reaction and there wasn't much management, but I did want to document it. I wanted to document it not only to cover myself and the liability against myself, but also to alert people in the future of what happened and make it aware for them to avoid using what we potentially think caused the reaction. So, unfortunately, in my situation, it wasn't ideal because this patient refused to take the Benadryl, and obviously I can't force her to take it. But thankfully, after we removed the substance, which was what we think was a topical anesthetic that was used, we removed it. I removed my gloves, and we tried to remove any leftover trace amount of it that might be in contact with her. She did start to decrease in redness and swelling. It was very slow moving. It didn't occur right away. We knew we weren't in an anaphylaxis kind of situation. And by the time she left, her reaction was completely resolved. So I did just to cover myself, give her a Benadryl and had her take it with her. But she did not want to take it. So again, I couldn't force her to take it, but we knew that it was a very, very mild reaction. It's something that she actually said that she gets weird skin reactions a lot of the time. So we weren't super concerned, but we want to make sure that we're still documenting and making sure that we don't do something like that in the future that could cause the same thing. Alright, so that concludes our lecture for this week. If you have any questions about the slide, if you've read anything that might be conflicting with the book versus the PowerPoint slides, please let me know. Email me. If you have any questions, email me. Don't wait till after you take the quiz. I want to make sure we're all on the same page and there's no miscommunication going on. Alright, so if I don't hear from you, I will see you next week.